John Wilson.
Thank you. Dr. Adams, I have a question about DMSA. There's a lot of statements out there about DMSA's ability to cross the blood-brain barrier, but I've never seen anything really substantiates that. Can you comment on that? That's question number one.
Sound check.
Yeah. Let's use this one temporary for the speaker.
So that's an excellent question. Vasaposhan, who was a former member of the Science Advisory Board, did some very interesting experiments in animals, and he found that of the different chelators, DMSA did not have a significant ability to cross the blood-brain barrier. Neither did most of the other chelators. DMPS had a very weak ability. There's one FDA-approved chelator, though, or it's not a chelator, but that does have the ability, and that's D-penicillamine. And so just before Vas retired, he and I were doing a project to look at D-penicillamine, and the unpublished results are yes, it is effective in removing mercury from the brain. It's the only substance we know that's able to do that. So it seems very intriguing. However, curiously enough, for the autism kids, we're seeing behavioral improvements with just the use of DMSA, and we think that's because it's targeting the brain stem, which is outside of the blood-brain barrier. And so we think that that's the part of the brain that's probably most vulnerable to exposure to toxic metals and is also the part that's accessible. So that's kind of a long-winded question. So there isn't any published research, but Vas's unpublished research shows that.
Apologize, the second mic is still being repaired. John, did you have another question?
Going here. Check.
Well, for Dr. Adams, I congratulate you on your ability to remember the question after that pause. You're not too mercury toxic, apparently. Secondly, about the legality issue of DMPS. It was on the bulk compounding pharmacy list for quite some years, but in 2002, when that federal judge eliminated the compounds that were on that list, it sort of floated off into the ozone. And some people think it's legal, some's not. The medical board in North Carolina wrote me a letter telling me that they think it's illegal, and if it's illegal, they can do this and this and this and this. So, and I've used it for thousands of doses of DMPS prior to that time. Do you have any really good evidence to show that it is legal to still use it, even though the bulk compounding pharmacy list no longer exists?
Yeah. My understanding is that it is still legal to compound it. That was as of 2005 when a group of 25 scientists and physicians wrote a consensus report on it, and that was our understanding. I'm not aware of anything that has changed, but you allude to a report that I'm not familiar with, so I won't say for sure.
Well, it was from a state medical board, which are not always the most up-to-date on these things, as you know.
I've got two questions. My first one is for Dr. Adams. In regards to a lot of the work you've been doing by measuring the mercury coming off of the amalgams and stuff, part of our study we're doing now is we removed amalgams from mannequins' teeth. We measured the vapor and then the particulate that came off the mannequin teeth with the amalgam. And now we're gathering samples of particulate off the head of the drill and we're measuring how much mercury outgasses over a period of time, and then finding out what the mass is of that particulate. So now we know a given mass and how much it outgasses over time. From a statistical standpoint, what would be the best way you think to put that information together? You have the separate vapor readings, the mass of particulate, and then the amount of vapor that comes off that particulate. We want to present this to our traditional dental friends to let them know the total dose that their employees might be breathing during the day.
I probably need to know a little bit more about the experimental design to be sure. Just to understand, you're taking amalgam fillings and you're drilling them out. Is that correct?
Correct. We're doing instantaneous readings of the vapor as it's happening. So now we know how much vapor came off over that period of time. Then we measure the particulate on the hard surface around where the patient's chest would be. And now we know how much mass of particulates left over, knowing the exact weight of the amalgam that we cut out. And now we're measuring the outgassing off that particulate over a 6-hour period to find out how much is actually coming off. To give you an example, we've done 4 so far, and the mass off the head of the drill has been averaging about 800 micrograms, and it peaks at 260 micrograms per cubic liter of air, and it takes almost 6 hours for it to get down to about 20.
Yeah, I mean, the amalgam's relatively soft compared to your drill, so hopefully you're not removing much material from the drill. I guess the challenge will be to collect all the particles that are removed. That's one of the challenges. The other challenge is that you need how you're collecting the vapor, because there have been several seriously flawed studies where they'll take a small piece of amalgam, put it in a sealed container, and that will only, once the vapor pressure builds up to the equilibrium vapor pressure, then no more gas will be, there'll be no net additional release of gas. So basically then the experiment is flawed. The larger the size vial you use, the larger amount of gas that will be released. And in the human, of course, you're not in a confined cage, so you're just going to continue outgassing. So I think in general, I need to still understand it a little bit better, but if you can capture all of the pieces and then also measure the amount of gas that's coming off, it would be possible in theory. But in practice, the amount of mercury that may come off in very small pieces that you could miss would make it difficult, I think.
Well, what we're using is we're using an atomic absorption spectrophotometer, and it runs 2 liters of air a minute through the test tube. And so we're seeing in real time. It's not a Jerome where you're just getting a snapshot. We're seeing in real time how much is actually coming off. And we start from 0, and we run it out about 6 hours.
Maybe we could talk after the meeting in more
Okay.
detail. But I think in principle what you're saying, trying to do makes sense. The problem is the amount of gas that's being released, the amount of mercury vapor could be very small compared to the mass of the particulates.
Right.
But still very, very serious.
Okay. My second question is for Dr. Fletches. We had an issue with fleas in our house after the very humid weather and the heat in North Carolina, and Holistic Vet told us to put borax all over the carpet and the upholstery that it would kill the fleas. So I wonder if you could comment on the insecticide properties of boron as well.
Yeah, it turns out that borax is toxic to insects. So if you put borax on the floor, like if you had an infestation of cockroaches in the house or at the office, you can put borax on the floor, and as the cockroaches walk through the borax, then they clean their feet off. They literally lick the borax off their feet, and it kills them. So borax to fleas, to cockroaches, to silverfish, to many different types of insects, borax is very toxic to them. And to us, borax is not toxic. Another product that's out there is cloves. You use cloves in dentistry to numb down tissue and so on. But if you take cloves and you whiz them up in a blender with some water and then spray the insect locations, the clove oil and clove particles also will kill insects. So boron and borax has a lot of good uses. In the dental industry, they've been taking borax and putting it into toothpaste, and they use it as a whitener for your teeth. And so you'll see some toothpaste that are being sold out there that contain some boron or borax in them. And again, you can use these and they're not going to hurt you at all. So the other thing that we saw was because boron increases the conversion to estrogen, or the boron to the testosterone to DHT. We've also seen the nitric oxide content of the bloodstream go up as these hormones go into effect. Remember, testosterone or DHT will increase the amount of nitric oxide in the bloodstream by 4,000%. That's, this helps to explain why we don't want our males to, from the day that any of you is diagnosed as having low testosterone, if you decide not to treat it, I'll guarantee you, you will be dead within 15 years. The average male will die within 15 years of being diagnosed as having andropause. Why? Because of the lack of nitric oxide, and hence the increased development of atherosclerosis. And in estrogen, it's virtually the same thing. Some people think that you got to stop the estrogen in men, because estrogen might be stimulating prostate cancer. And what we're finding is that if you give drugs to inhibit the development of prostate cancer and to stop the production of estrogen in the body, that the patients will die from a heart attack sooner than they would from the prostate cancer, only because estrogen stimulates the making of nitric oxide. So estrogen in men is not an enemy, it's your friend.
A question for Dr. Ten. Concerning the anti-inflammatory.
Can I just add something? It's about the toxin. A mosquito was heard to complain that the chemist had poisoned his brain. The cause of his sorrow was paradichloro-diphenyl 3-chloropane.
So with the anti-inflammatory properties of tocotrienols, do you have any evidence that it acts at the nuclear level, at the DNA level, with suppressing nuclear factor kappa B, for example?
The NF-kappa B? Yeah. There have been published work on tocotrienol on NF-kappa B. In the more downstream type analysis, people have studied tocotrienol tumor necrosis factor, even further downstream, the synthesis of the protein, the hepatic protein that's used in doctor's office all the time, like the C-reactive protein, those similarly drop. Dr. Qureshi did a study. What he wanted to, from University of Missouri Medical School, what he wanted to do would be an NSAID drug replacement. That's his intent. And he sifted out 20, 30 different compounds and reduced to 3. If any of you interested, email me, I can send it to you. Very fascinating study. He's a very eccentric guy. He would do dozens and dozens of cell line study, and then he'd do probably half a dozen animal study, and finally he did clinical study. By the time he sifted it down to clinical study, he reduced the 3 most active compounds to delta tocotrienol, quercetin, riboflavin, one of the B vitamin, and one is escaping my mind now. There's another one. But in the clinical study, he used 3 of these compounds, and he saw for people who are inflamed, inflammatory responses drop, and some of them have hypercholesterolemia, they drop too. So that's compelling. I'm just looking for somebody in the industry who would make a formulation like that, kind of like a anti-inflammatory, non-NSAID nutritional supplement, you know. But he measured all of these compounds, and they're all coming, more and more so that I've seen.
Next question. John.
For Dr. Tan, you'd mentioned that tocopherols can interfere with the function of the tocotrienols. Many of my patients take a multivitamin that contains D-alpha tocopherol in like a 400 unit dose a day. Is that an interference that would have to be eliminated to be successful in using tocotrienols?
I can give you a personal answer as well as one that people take. If people take tocopherol and they would not want to give it up, I don't know why they don't want to give it up, because there are so many large-scale clinical studies. This alpha tocopherol is simply not panning out. It's just not panning out. Anyway, if they must want to take it, then they should take it in the morning, at least 6 to 12 hours apart from taking the tocotrienol. You're playing with the pharmacokinetics. That's all that is to it. The only part that I can see alpha tocopherol as a benefit as a scientist would be that it will protect the LDL particle. But you know, to protect the LDL particle, the 30 IU, which is about 20 milligrams, that would come from my normal taking of cereal in the morning, a vegetable oil for cooking, and some greens. That would give me my 20 milligrams. So any additional would not be 30 IU. So 400 IU would be fantastically high. If that 400 IU, which is approximately 300 or so milligrams, were to be taken with tocotrienol, there would be little prayer that the tocotrienol would absorb. So taking separate would be good.
Next question. Yes, right here.
Okay. Dr. Adams? Yes, in your study, you had shown that over the course of time, given the DMSA, the mercury levels continued to come out at a relatively constant rate over the course, but the glutathione levels seemed to correct relatively early. Is there and a reason for that? I kind of thought the mercury would have been more involved in the glutathione reduction, and yet only one application, I believe it was, or one 3-day application of DMSA seemed to idealize the glutathione.
Yes, we found that just one round, so 3 days of oral DMSA was sufficient to normalize the glutathione. That may not have, and that was stable for 1 to 2 months later, so we measured it 1 to 2 months later after that dosage, so it helped for at least that long. I think longer term, probably more DMSA might be needed for the individuals who still needed it. So in our study, 20% of the kids with autism did not have high excretion, 20% had excretion for only 1 to 2 months, but 60% were still excreting high amounts after about 6 months. The DMSA primarily goes after lead, so although there was some increase in excretion of mercury, it was modest. And I think our experience of clinicians that I've worked with has been that once the lead is significantly decreased, then DMSA will be able to pull out more mercury. But when lead is present, the DMSA will preferentially bind to the lead and won't remove very much mercury.
All right, thank you. I have other questions if somebody else doesn't need it. Let's see. Dr. Tang, about the angiogenesis inhibition, are there studies to show that that is a specific angiogenesis inhibition regards to tumors and not necessarily limiting, let's say, a post-trauma healing or angiogenesis in response to a surgery and that type of angiogenesis?
The only studies that's been done on angiogenesis currently is with the tumor one. So, and we are hoping to do a study with diabetic retinopathy, but I couldn't get the program going because that would be a huge number of people with diabetic retinopathy, I couldn't get that implemented. And I'm still looking for somebody else. Hopefully this might work. For people with macular edema, the swelling of the macula, and that also is underwritten by angiogenesis. And I found an ophthalmologist, so we might just be lucky to pursue that. If we are able to do that, there will be the first anti-angiogenic study, at least in the planning stage, that's not directly to do with cancer.
So I guess with respect to normal wound healing, though, it doesn't seem to have any interference with that type of angiogenesis.
A very good question. Apparently not. You know, there is a NIH funding currently going on. It's about $2.5 million, Ohio State University, that specifically use vitamin E tocotrienol for wound healing. So therefore, it's a lot of underpinning of angiogenesis, which is important to wound healing, and then which is not good for cancer, left to be understood. And by the way, we are also conducting a study in gynecology for the development of the fetus, and that's a lot of angiogenesis happening there, you know. So so far the preliminary study looks very hopeful, but I don't have a good handle on the angiogenic growth there. Almost I'm talking the opposite to what I show in the slide. Do you know what I mean? All I could say is angiogenic growth in cancer is very aberrant. The way that they make those tissue are not like your normal artery. It's just like a quick fix, a plumber's job, you know, to abscond nutrient from the nearby artery. But that's all I could say now. So hopefully in another year or two we may have better answers to that. Thank you for the question. I think it's a very insightful one.
Dr. Adams, prior to having my patients go to have their mercury amalgams removed, I would have routinely prescribed 20 milligrams per kilogram dose of DMSA to take 45 to 60 minutes prior to the extraction process. Do you have any comments about the efficacy of that?
Let me just see if I understand you correctly. So before you have them remove their amalgams, you give them an oral dose of DMSA a few hours beforehand?
No, 45 to 60 minutes to allow for absorption and have blood level at the time the mercury molecules are misbehaving.
I think that makes very good sense. That oral DMSA has a half-life of about 24 hours in the body. When you take it orally, the level will peak at 4 hours, but the half-life is about 24 hours. So you're well within that window, and I think that would be very effective. However, I think it's also possible just to boost glutathione, because glutathione, although it has only a single binding site to mercury, so it doesn't bind it very strongly, it binds it strongly enough that when you're initially exposed to mercury, it can remove it. It just once mercury is present for a long period of time, then the glutathione won't be able to move it once it's bound to brain or kidney tissue. But using DMSA prophylactically, I think, is an excellent idea. I think glutathione would probably work almost as well. Giving glutathione is tricky. You can do it IV. There are several studies, including some we've done, that shows that giving it orally or transdermally really does not work well. So instead, there are many other ways to increase glutathione production. Some of them, giving folinic acid with methyl B12 is one approach. Giving NADH, which is the active form of vitamin B3, we found worked well. Giving, there are several other approaches as well, but those are some of the best ones.
Just one moment. This is being recorded. This is why we're getting the mic here. Thank you for waiting for the mic.
Sorry. Just to clarify, you give the DMSA, you're saying it peaks at 4 hours, so would that be the ideal window, 4 hours prior to the visit?
Yeah, I suppose that's actually a good point, that it would probably be best to give it about 4 hours. But I don't think you have to be too strict about that, because although it's peaking, the mercury is not going to instantly go from the bloodstream into the tissue. The half-life of mercury in the blood is several weeks. So I think if you're just giving it any time within that day or so. But yes, probably 4 hours beforehand would be optimal.
And what would be the dosing?
That's a good question. I don't
For
know for
adults.
sure because it probably depends on how much exposure there is. I could probably try to estimate that, but I don't know. The standard dosing for oral DMSA is 30 milligrams per kilogram body weight. That's what the PDR uses. They usually recommend splitting it into 3 divided doses daily. But that's probably a pretty safe amount. And you can probably do it for 2 to 3 days safely. If you get up to 5 days or so, that's when you begin to see some side effects, because the DMSA will remove some essential minerals.
Thank you.
Next question. John, I can see it in your eyes.
I wanted to just make a comment about DMPS, which is 55% absorbed orally, versus the DMSA, which is about 20 to 25% absorbed. And I had a patient back in the mid-90s who came to see me, a young gentleman in his mid-30s who was slightly built, who had a mouthful of amalgam fillings, and his major complaint was fatigue and mental fog. And I had him get his mercury amalgams out, and I started treating him with DMPS. And he excreted 35 micrograms per gram of creatinine in his urine following DMPS challenge. But interestingly, he woke up and he got his brain back, his energy came back, but about a month later, he was back where he started. And I did a series of, over the course of a year and a half, 35 DMPS infusions with this gentleman, and got his post-challenge urine level down to 2 micrograms per gram of creatinine, but his symptoms every time was the same yo-yo. And then by then I hung around with Klinghardt and took some DMPS and mixed it with 9 cc's of 1 cc of DMPS mixed with 9 cc's of procaine, and I injected his tonsils to get into the superior cervical ganglia, and did segmental therapy over his liver, spleen, and kidneys, and measured his urine afterwards, and came back at 400 micrograms per gram of creatinine. So I was really impressed with how deeply stored the mercury can be. And when you go after some of the deeper depots, it can be quite a long time before you can start really shaking it down. And with regard to the DMSA before mercury removal, DMPS would probably make better sense because it's more affection for inorganic mercury than DMSA, which goes after the organic more so than the inorganic with DMSA.
But yeah, I'd certainly agree that DMPS is more effective for binding to mercury, and so that would be better if you're comfortable using that. And I think that from a scientific point of view, it makes very good sense. I didn't catch what was the compound you gave with DMPS in order to boost excretion.
Procaine, which is just basically used in neural therapy as a way of kind of resetting the ganglia, but it can actually carry the DMPS into the deeper tissues if you administer it that way.
Interesting. I'd like to hear about that more later.
Next question. Yes, Mark.
Dr. Beckman, in your observed 92% success rate with the zirconium implants, does that allow for, or do you allow for immediate placement upon extraction, or do you always implant into a healed crest?
Hello? Is it working? Okay. It's very individual. Normally, when you've extracted the tooth, you take away the bone on the inside of the alveol and leaves the bone free. And that creates a hole that could be too big for the implant. But sometimes when there's not so big difference between the implant and the created hole, you can put it in immediately. So I use both. Depends on the patient. Or I don't have any rules for it. It depends on how I judge it.
May I ask what the integration time is for ceramic implants? The integration time, 3 months, 6 months, is it a standard? Or
That's also individual, but in my statistics, I reckon that between 120 to 160 days before I load them.
How
so
many?
That'll make 4 or 5 months. But it tends to go down because I get more and more courageous. So it also depends on where it is, but if there's a fast grip on it, and you can also do a temporary crown on it immediately sometimes. Okay. There's no rule for it, but varies between 4 and 5 months.
Dr. Beckman, I came in late, so if you answered this question already, please forgive me. From what I saw, you mentioned if the depth of the bone it's not deep enough, you could insert a little balloon and then insert something that will cause calcification in that balloon, and then put the implant in there. Did I understand that correctly when I listened to your lecture?
The question is, well, I'm sorry, didn't catch the question. The last sentence.
That if the depth of the bone in which you want to place an implant isn't deep enough, you could insert a small balloon, and then into the balloon, where there's not enough bone, insert something that will cause calcification, bone to form, so that you could later insert a dental implant into that area?
Yes, the balloon is only one way to lift the Schneider membrane, the mucosa inside the sinus. You can also use, there's another gadget which is like an implant with a hole in it, connected to a plastic tube and a syringe. And you can simply press in physiological water under the membrane and have it, get it lifting. The thing is to separate it from the bone and to get it loose, and then you can put in just anything under it. The balloon is only one way to lift it, and then you inflate the balloon and takes it out. The balloon is connected with a tube to a syringe, that one too. It's a bit, you have to be careful in the beginning because I don't know, the balloon works like this. You press and press and press, and then all of a sudden it just gives away. So you have to get over that first stage very slowly to not rupture the mucosa.
Okay, thank you.
Question?
I just have a question about the boron supplementation. When we're doing dental surgery and we're anticipating a big extraction case, and then pre and post-op supplementation of boron, and how you think that could be helpful.
Could you please talk a bit slowly? I'm from the other side of the Atlantic, and I just don't follow you. Could you take it just once again, but make it slowly?
The question is for whom?
It's not for me.
It's about the boron lecture.
Okay, it's for Dr. Fleshas.
Sorry. No, sorry. No, I was thinking during the lecture about, because I do a lot of surgery as far as extractions and cavitations and such, that if pre and post-op supplementation of boron, and how you think that would help as far as healing.
You know, when boron gets into the body, it converts into two products. One is boric acid, which can get into the saliva, and so the saliva boric acid levels go up. So it would help to decrease infection rates. It also helps to suppress an overactive immune system that goes wild on you. So I'd say, you know, give some boron before and after to see if that will help to keep the infection rate down, and also help you with bone healing. As you saw from those rat studies, boron does stimulate osteogenesis, and it does help you to build new bone structures. So
It would be orally. I mean, you wouldn't place boron into an extraction site?
No, you take it orally.
Okay. All right. Thank you.
Thank you. Another question? Yeah.
Just for, well, while you have the microphone for Dr. Fletches, is there any benefit to taking the supplement DIM for the conversion of testosterone to dihydrotestosterone? Have you heard of that?
Try that again.
The supplement DIM, D-I-M-M, to help convert the testosterone to dihydrotestosterone.
Right.
Is that a benefit?
I think, one of the reasons we take them is to decrease the estrogen stimulation. And frankly, again, estrogen is one of your good friends. Estrogen in the males is not something we want to try to get rid of. And, we want more dihydrotestosterone there to help with the tissues of the body.
Okay.
Yeah.
The second question is for Dr. Adams and/or Dr. Wilson over here, but where you were talking about the pretreatment with DMPS or DMSA prior to amalgam removal. What about it mobilizing the mercury burden that's already there, in addition to whatever exposure they may get?
I know there's been a lot of speculation about the thought that that chelators like DMSA or DMPS are going to mobilize or move mercury from one part of the body to another. It doesn't seem plausible. These chelators bind very strongly to mercury, and I think it's very unlikely that they'll do that. There is one study where DMPS was given, and it did very slightly increase the level in the brain temporarily, but then continued treatment had a very slight effect on removing it slowly. But it doesn't, I don't think that's a very significant effect. But there could be more research to really verify that. Vasopotion looked at that a fair bit. That was one of his concerns, and his conclusion was no, there really wasn't any significant movement of mercury from the rest of the body into the brain. Yeah, I couldn't hear the question, I'm sorry.
Either that, the mobilization, or the competition of it working at the tissues as well as the acute exposure.
I mean, mercury is basically going to go to the sulfhydro groups present in the brain and the kidneys, and to some extent there'll be some in the liver as well. But the two binding sites in the chelators on DMSA and DMPS, once it binds to those sites, it seems to remove it quite effectively. The trick is getting it into the brain, because those chelators are not able to bypass the blood-brain barrier very effectively. But, we happen to have another mercury expert here, and I don't know if he'd care to comment on that. I'll put Mike on the spot.
The question is whether DMSA and DMPS cross the blood-brain barrier? They don't.
I'd like to comment on that question too, because the DMPS and DMSA are both hydrophilic compounds, and I've been always I sort of learned a lesson about that back in the mid-90s when I had a young woman come to me with about 12 amalgam fillings in her mouth, and she had a lot of symptoms of mercury toxicity, and I thought, well, using it while she still has fillings is like trying to dry off while you're standing in a shower. But I thought, but for every molecule of mercury we remove, it's all the better for her. So I went ahead and treated her anyway while I tried to cajole her into getting amalgam fillings removed. And after several months of treatment, she went back to her dentist, and he was aghast at what her amalgams looked like. And the only thing I could assume is that they looked like they'd been dissolved and I that time stopped the DMPS until she had her amalgam fillings removed, and when she was eventually recovered. But you know, I think that you know, it taught me just to be concerned about the possibility of this partitioning to the saliva, and I'd rather have the dentist take the fillings out than have the patient pee them out through their kidneys.
The way that DMPS and DMSA remove some of the mercury from the brain is essentially what you're doing with DMPS and DMSA. You remove most of it from soft tissues and from the blood. And as you're doing that, you're actually building up a concentration gradient between the brain and the blood. There's always free mercury. It binds very tightly to sulfide groups on glutathione, on every enzyme pretty much. The KD of mercury binding to cysteine groups is in the order of 10 to the power of 23. There's no other compound that binds to SH groups or any other endogenous ligand the way that mercury bonds to SH groups. So what you're doing, as I said, is because there's always a little bit of free mercury in the brain, in any other tissue, as you're removing the mercury from the blood and you're building up this concentration gradient, some of it just diffuses basically out. But it's very hard to remove the mercury out of the brain. The mercury in blood, the half-life, methylmercury, there's differences between them. There's about, on the order of about 60 days. The half-life of mercury in the brain is much, much longer than that.
This is a question directed to Dr. Fleischers. Yesterday you spoke of a female athlete and the treatment with iodine, and could you comment a little further on the treatment on male athletes of the same age range?
Again, in both the male and the female, it is estrogen that turns off the growth plates on the bone. I've heard now that there have been in Russia that if you wanted to have very tall athletes, that they were giving these Russian athletes in their teenage years, they were giving them iodine to inhibit the making of estrogen. And as a result, they were getting athletes that were somewhere between 6'2" and 6'6". So it basically has been used. It's the Russian athletic people have already figured out that if you inhibit estrogen, the making of estrogen, that you can generate some much taller humans. And again, iodine inhibits the making of estrogen at the DNA level. If there's 16 steps to making estrogen, iodine inhibits 14 of the 16 steps. So, and we became very much aware of that when we were giving iodine to women that were postmenopausal on estrogen to treat their hot flashes. And as soon as they started taking iodine, all of a sudden the hot flashes came back. And that's because we were cutting off the making of estrogen at the DNA level. So iodine does affect the DNA. And that was work that was published by Dr. Bernard Eskin, E-S-K-I-N, and he's from Drexel University in Philadelphia. And that paper can be downloaded off the internet, but it was published like 4 or 5 years ago now.
Other questions?
Dr. Fleischer, we've heard about iodine and boron and oxytocin. What else is on the horizon that we should be thinking about? I mean, other trace elements give us your thoughts about the future there.
It depends upon this academy and what they want, but there's been a lot of work that's been done on the topic of silicone, and it turns out that the #1 element on the Earth is oxygen, Number 2 element is silicone. And if you combine silicone with silicone with oxygen, you get silica, which is sand, quartz, opal, and it turns out that the human body is very dependent upon opal for normal function. And with the use of opal, we can reverse Alzheimer's, and we can also treat atherosclerosis, and we can reverse atherosclerosis with the use of this type of silica. So there's more to come. So it's just an issue of what the Academy wants.
Okay, Dr. Ashner, I'd like to ask a question of your opinion, I guess, on, you're saying mercury in the brain is bound very tightly and it's hard to get in there and get it out. Are you familiar with Dr. Haley's recipe of what, could you just speak a bit to what you think of that?
I'm familiar with Dr. Haley, not with his recipe.
Okay, well, I guess my question would be with respect to his compound, the OSR, that he's in the midst of trying to get to be able to sell. Do you feel that that's a compound that has a strong ability to be used?
So I don't know anything about the compound, but obviously for something to be effective in removing mercury from the brain, it has to get in. So the capillaries of the blood-brain barrier are very different than capillaries in the kidney, in your arm, any other tissue, because they're what's known as non-fenestrated capillaries. The outer membrane physically join each other, so there's no room for anything to diffuse between cells. So in order to get something in, it has to be of pretty low molecular weight, and it has to have a transporter, or it has to be lipid soluble. So DMSA and DMPS are not lipid soluble, and they're big, and there's no transporter for them. So if this compound has a specific transporter, I talked about methylmercury and how it binds to AAT, for example. If this binds to another transporter, which is expressed on the membrane, it would get in. Once it gets in, if it binds to mercury, and if it has a mechanism of getting out, which is another issue, then it would be effective, yes.
I reviewed some of Dr. Haley's animal studies, and I'll just say it looked promising for animals. It did seem to have an ability to sequester mercury and remove some of the toxic effects of mercury, but it's just animal studies right now, and we're waiting for human trials.
Thank you.
During the last conference in Charleston, I mentioned the use of iodine to help get rid of mercury. And it turns out that you talk about all these chelating agents, but chelating agents are bivalent. Iodine is monovalent, and it grabs a hold of things by using what's known as the chiotropic effect. Chiotropic is what happens when you take iodine and you attach it to something, and that combination of iodine plus that something makes it more water soluble. Illustration, chiotropic effect of iodine on mucus plugs in patients with asthma and COPD. It's known as, it has the ability to take these hard mucus plugs and make them liquefied, otherwise known as the mucolytic effect of iodine on the proteins of the lungs to liquefy those proteins. Well, iodine has a transporter that can transport high doses of iodine into the brain, and it can do it within it can transport iodine into the brain within a period of about 30 minutes to an hour after you take the iodine. Iodine does have the ability as monovalent and through this chiotropic effect to get down all the way down to the mitochondria, grab a hold of iodine, mercury, and suck it back out. And it makes the mercury water soluble so that it can literally walk its way back out with it.
That sounds great.
Yeah, but that's something to look at rather than these chelating agents, which are divalent and massive molecules, and they have problems. iodine doesn't have that problem.
And since we're on the topic a bit and you have the mic, fluoride is also a concern of a lot of members here as well, and iodine has been spoken of as a chelator somewhat for fluoride as well. Could you speak to its benefit that way somewhat?
Actually, iodine fluoride likes to hide inside the bones, and iodine goes into the bone and literally displaces the fluoride out of the bone, and so then the fluoride gets into the bloodstream and then you urinate it back out. But some of the initial studies that we did about 10 years ago were published in the Townsend Letter showing that the fluoride levels go very dramatically up in the presence of just taking some iodine.
Fabulous, yeah, sounds good.
Dr. Fletches, does iodine have any potential benefit for eliminating dental fluorosis with children or adults?
I've not seen it do any dental fluorosis. Yeah, not seen that one. She wants to know, is iodine toxic? No. And the reason I say that is based upon the research that's been done over the last 150 years, that if the body can't use iodine, you'll urinate it out. It goes out through the urine. And if you saturate the body, you'll just urinate it back out. So historically, one of the problems of medicine is that we forget history. And I'm sure it happens in dentistry. But in medicine, for years, we've been giving iodine, like for patient, John, for years, patients with COPD, asthma, and so on, how much SSKI were we giving for treatment of asthma and COPD? We were giving over 400 milligram 4 times a day. 1,100 milligrams of iodine per day just for treatment of asthma and so on with SSKI. The dermatology people, as of 70 or 80 years ago, were giving over 12 grams of iodine per day for treatment of fungal infections in the body. If you forget history, you're going to start making the same mistakes that we've had in the past. And this is the issue. Nowadays, people think that if you're taking greater than 500 micrograms of iodine, it's going to be toxic to the body. And these doctors are just totally ignorant to the fact that for years, medicine has been using very high doses of iodine for treatment of diseases with no complicating problems.
Well, it's 5:30. Can we have one more question?
Have you seen, Dr. Fletcher, anybody develop hyperthyroidism-like symptoms taking too much iodine?
Sure. And what happens is that if you have a thyroid nodule, or nodules of the thyroid, or multinodular goiter, some nodules are hot. And whether you give them just a little bit of iodine or a tremendous amount of iodine, these nodules will go hyperactive. And they already were hyperactive to start with. So anytime you start somebody on iodine, check their T4 and T3, check their T4 and TSH at the very beginning of therapy. Repeat your T4 and TSH at the end of a month. And if you see the TSH plummeting and the T4 levels going up, like a T4 that goes from 7.5 to 14, that should be telling you that maybe there's a problem with a hyperactive thyroid. A hyperactive thyroid nodule. These hot nodules can give you hyperactivity. And so it's something to be watchful for. And in fact, my last patient that I treated, his T4 was 7.4, brought him back in a month later after giving him some iodine, and his T4 had gone up to 18. And he was having insomnia, his heart was palpitating, his hands were sweaty. He had all the symptoms of hyperthyroidism. So we stopped the iodine, his hyperthyroidism calmed down, and now he takes iodine about once a week, has no symptoms whatsoever. But if you give it to him every day, he definitely will go hyper. So it does happen.
Well, let's give a hand to our speakers. And thanks, everybody, for coming. We had another great meeting.